not least, I'd like to introduce my very dear colleague, Dorothy Bulas, who I've had the joy of working with now longer than we're going to admit to. And she's going to talk about really maximizing your use of the skeletal survey. Dorothy, thank you so much for being with us today.
Well, it's my pleasure, and a great way to start January. I have to admit that a lot of times when I give this talk to my radiology trainees, residents, I do have to lock the door before I tell them the title, because skeletal dysplasia is something that many radiologists fear. And what I'm really trying to do today is just show everyone why we do need a full skeletal survey and what we get out of each image. So we'll talk about the systematic approach to this survey, and again, just touch briefly on the radiation dose. I just wanted to throw that in there, but since we're really only doing single AP views and most of the images are of the skeleton, you're not hitting much of the gonads and the thyroid gland, and the doses which sometimes families are concerned about are quite low. So you do want to reassure your families when you're asking for a skeletal survey that although it seems like usually it's about 25 or 26 images, that really the amount of radiation is less than like a year of background radiation, you know, just kind of living in DC. So I'm not going to really talk to the experts here about skeletal dysplasias, but it's really hard, and why the radiologists are so worried about them is that there's so many and they're so rare. So it really becomes a double-edged sword. We learn by looking at 10,000 films. We learn by repetitive looking at abnormalities, and we don't have that luxury with the skeletal dysplasias. So Fine Hall years ago had a really nice article aimed at radiologists in pediatrics, you know, how to get to the approach, and I have stolen from it. And I always like to mention, give a shout out to how they presented their details. And we'll kind of look at the osteochondrodysplasias and dystostoses, and just to remind you that with the chondrodysplasias, it's an intrinsic abnormality. So they tend to affect all the bones, though some of the bones are more affected than others. The most important thing to remember is that there is, over time, the skeletal surveys can change. So it's not that unusual to have a skeletal survey in the newborn period not give us the information we need, and yet it becomes very obvious when you repeat it at 10 or 12 years of age. And then, so we talk about the fourth dimension, that it kind of does change over time, and it may either be an Aunt Minnie early on, or it becomes more obvious in the future. We also will come across the dystostoses, which are more of the defective bone formation. Usually those don't change over time. It's a one-off. You'll see the abnormality in the newborn period. It's pretty static. It'll look pretty similar if you got a follow-up film at 10 years of age. And these, you may not really need to have a full skeletal survey. And you know, there are a couple of different groups for dystostoses, and just throughout here, this is a fetus. I do a lot of fetal imaging, and so I do actually a lot of fetal diagnoses of skeletal dysplasias now. And we really want to, again, look at the entire fetus to give us hints about what's going on. So here we're seeing fused hands. There's a little bit of brachycephaly of the skull, and this was an upwards with craniosynostosis. Again, a dystosis with you know, radial ray anomalies like a Holter-Ran. So this is going to look pretty similar. I mean, the patient will be growing over the years, but you're going to have a single forearm and this bowed humerus forever. So with the dysplasias, you have abnormal growth of many of the bones. It's relatively symmetric. It's you know, failure of genetic expression. It's evolutionary, so it can change and look differently over time. While the dystostoses, you can have a single abnormal structure, and it really is pretty static. And then on top of all this, we also have the systemic effects in the bone, which can end up mimicking changes to the epiphysis, metaphysis, and physis. So like hypothyroidism or rickets, all of these can mimic a metaphyseal dysplasia or an epiphyseal dysplasia. So we have to be aware of them and to always give that differential. And as a radiologist, we so depend on the clinicians ordering the exams to just be aware that the last thing we want to do is come up with a single diagnosis, which is incorrect. So our job really as radiologists is to just help you kind of go further in your searching of what the diagnosis is. But I do try to remind our, and like my last slide is that the biggest mistake we can do is to give a wrong diagnosis. So giving a differential, I think, is more useful to you all than a single diagnosis that's incorrect. So the skeletal survey. We do want an AP lateral skull. We do need an AP lateral spine. And those do have a bit of radiation. The skull, you're going to irradiate the orbits, the lens, which is something that we do worry about because you do have a set dose of radiation, like after 100 milligrams of radiation to the lens, you may start developing cataracts. Then a single AP chest and pelvis, and then we may be able to do just a single upper and lower extremity if they're symmetric. And if you're going to do a single hand, do one hand, do the left hand, so we can do a bone age. So looking at the skull, we're going to be looking at the sutures. We might look for Wormian bones, see how big the fontanelle is. Very useful to see how thin the skull base is. That gives me some sense about whether there is osteopenia. We can also look at sella. And then we also look at the craniofacial proportions. So, so that's important to just give a global sense of whether there could be craniosynostosis or not. Spine, a lot is going on here. So we're going to be looking at alignment, the shape, whether there's segmentation anomalies, and looking at the normal vertebra. We want to look for posterior scalloping, end plate irregularities, flattening of the vertebra, and you can have beaking. You can have actual wedging anteriorly or posteriorly. They can be flat, they can be tall, and they can have short pedicles like in chondroplasia, or coronal clefts with some of our differentials. We also want to look at the AP of the spine, and normally the pedicles should actually widen a little bit as you go inferiorly. And if they stay narrow or even narrow further as you go down the lumbar spine, you want to be worried again about achondroplasia. The chest, we're going to be looking at the number of ribs, but also, I'm so sorry, I shouldn't be working here, but the number of ribs, whether there is fusion, and we want to know whether the clavicles or scapula are actually present. When we get the AP views of the pelvis, we're going to be looking for pubic bone ossification. There's a lot happening with the acetabulum and the proximal femurs, and then we look at the shape of the iliac wings and the sacroiliac notches. So this is a very important view that you shouldn't be cutting off of. And then when you get the extremities, whether you do one or both of them, we're looking at whether your epiphyses have ossified or not. Are they irregular? Are they homogeneous? Is the physis open? What does the metaphysis look like? Is it flared? And then looking at the diaphysis. So we're looking for thickness and marginal irregularity. We do want to get the hands and feet. So we're going to get a bone age with the left hand. We can get odd fusion anomalies. And again, there could be polydactyly, there can be other accessory bones, fusion of the tarsal intercarpals. Those are all things that can give us hints about the diagnosis. And some people ask, well, you know, if you have a small baby, why don't we just get one large field of view and just include the entire infant on the image? That normally you're not going to have good positioning of all the extremities. You're going to miss something, and it actually, if it's a live child, you may be over radiating for the images that you want to get, and you may have to end up repeating some of those images. Certainly for stillbirths, though, babygramms are fine. And then for preterm infants, small infants, I'll certainly sometimes do a full large field of view of the pelvis to the feet, or, you know, chest, including the spine. But you don't want to get a large field of view including both arms and feet, because it's a bed of radiation and you're not getting optimal positioning. Don't forget that you may want to survey family members, and sometimes we may not be able to make the diagnosis early in a young child, but the parent may be affected as well, and we may be able to see some very specific diagnoses and come up with the diagnosis by looking at the older family members. And then, as I mentioned, with that fourth dimension, you may want to get some follow-up films in a couple years if we haven't come up with a specific diagnosis initially. So just an example of how a parent can help. So this was an 8-year-old who was starting to, was growing okay, but by about 3 or 4 years of age was slowing down. So was now had short stature, and the interpedicular distances look kind of like they widen. The sacrosciatic notch doesn't look too bad. You might state that the femoral epiphyses are a little bit small in an 8-year-old. This is the father, who was also short. You know, very striking varus deformities, narrow interpedicular distance, and we were able to make the diagnosis of pseudoachondroplasia much more easily in the father than in the younger child. So sometimes we don't have to work that hard or wait many years to make the diagnosis. Look at the parents. So after you do your skeletal survey, we're going to be looking at each of the bones for location. Are there any complications? And with the axial bones, you're going to be looking at the ribs and the spine together, the skull, and figuring out which of the bones are actually affected. And I don't mean by humerus or radius necessarily, but be comfortable with the anatomic location. If there is humeral or femoral abnormalities, that they're sure you will have like rhizomelic shortening. If it's a tib fib or radius et ulna, it's mesomelic. If it's the hands or feet, we'll call that acromelic. And very often you can have one or more of these combined. So micromelia would be shortening of all these. And this is a drawing which I've really liked to use over the years to just help remind me about how the bone grows and how different dysplasias affect different parts of the bone. So we'll kind of refer to this picture for the next few minutes of the talk, but just remember that the epiphysis will have like an ossified center. It kind of grows in a circular pattern with its own surrounding cartilage. And then you have the physis, which has like the columnar growth. And then you have the metaphysis with zona for visual calcification. And then you have the osteoclastic and osteoblastic activity that kind of forms what the diaphysis looks like. And some of the dysplasias will really affect primarily the epiphysis. Other times it's primarily the diaphysis. And at least using that same nomenclature can be very useful as you're talking to clinicians. So when we're just looking at the bones again, the B's include looking at exostoses, looking at the shape, looking at the size, is it small or large, the number, and also if there's some soft tissue abnormalities, that can also give you some clues to the diagnosis. So for growth, again, remember that with the epiphysis, you're going to be in a kind of hemispheric growth pattern. but if you do have epiphyseal abnormalities and growth, they will end up being fairly short. But the most severe disturbances of growth are at the physis. So these will end up resulting in the shortest skeletal dysplasias. The metaphyses may have some flaring, and then your cylindrification that occurs with the diaphysis. And you can have both overgrowth and undergrowth of the epiphysis, physis, metaphysis, and diaphysis. So as you start looking at the epiphysis, if it looks like there's an overgrowth, you can just start narrowing the diagnosis down to just a couple. It's pretty rare to have overgrowth of the epiphysis, and you could think about Trevor's disease, which is pretty rare. Now, if it's hypoplastic, we have a larger number of abnormalities that can be, an Aunt Minnie is the chondrodysplasia calcificans, but then you can also have your multiple epiphyseal dysplasias and your spondyloepiphyseal dysplasias, depending on how much of the end plates of the spine are affected. So this kind of Aunt Minnie of the chondrodysplasia calcificans, you can get these very bizarre punctate calcifications in the carpals, around the epiphyses, even in the newborn period, when none of these should be ossified. And interestingly, over the years, as they get older, your tarsals and carpals and epiphyses start to normalize. So it's actually much easier to make the diagnosis early on if it's a tardive form than later on when they're 10 or 12. And you may see odd ossifications. Here the tracheas abnormally ossified. And here you have, again, unusual calcifications of the epiphysis. So some can be fairly subtle. You can have these strange little tufts that are hypoplastic. So again, just looking at the spine or just looking at the pelvis, you may not get the clues that you really need to come up with this diagnosis. So for over and undergrowth of epiphysis, do remember that with hypothyroidism, you can mimic the epiphyseal dysplasias because it also affects the growth of the epiphysis. They can have a delayed bone age, but all the epiphyses can look somewhat stippled. And Morchios also, for the Mucopolysaccharidosis, Morchios is the one where the epiphysis is the most affected. And remember, these are the children that probably have the most severe skeletal abnormalities, but their CNS is not as bad. So you want to be looking at the spine in particular in these cases. You can see shortened vertebral vertebra. The dens in particular is going to be hypoplastic. You want to remember that these cases can have C1, C2 subluxation abnormalities. And here, as in all the mucopolysaccharidoses, you kind of have kind of a little bit widening of the metacarpals, and it may be a little hard to recognize that the epiphyses are abnormal, but getting the bone age can help. And the gibbous deformity is something that you may see in any of the mucopolysaccharidoses, but again, can help you in thinking, oh, let me think about mucopolysaccharidosis, and oh, the dens look short, oh, the epiphyses look a bit irregular, let me think about Morchios. Now, I just threw dystrophic dysplasia in the epiphyseal category. It doesn't really fit any of the good epiphyseal, diaphyseal, metaphyseal areas, but their epiphyses are fairly abnormal, and this is a bit of an Aunt Minnie. If you have that hitchhiker's thumb, think about the dystrophic dysplasias, and very many of the patients that come to us with achondroplasia with club feet, remember those are most likely going to be dystrophic dysplasias. Now with the physis, with hyperplasia, we can have the enchondromatosis, and with the hypoplasias, the whole achondroplasia group, and the metaphyseal dystostoses. So with overgrowth, they can look very bizarre, like these snowflake appearance to some of the cartilage. They can look very short or angled, and it may, because they're somewhat asymmetric, you may not really be thinking initially that this is enchondromatosis. and you can kind of result with these Madelung's deformity. And some of them just look like there's some unusual widening or even a tumor in the metaphyses. Others are just much more dramatically short and deformed. The achondroplasia group will talk mostly about the achondroplasia. A hypochondroplasia does also affect the physis, but it's less severe. But we'll have narrowing of the interpendicular distance. I do see a lot of thanatophoric dysplasias in my fetal work, but you're not going to see them because they are indeed lethal. And all of them have the FGFR3 mutations. So when you kind of look at the physis, it's very abnormal. You're going to just kind of lose that proliferative zone. You don't have that columnization. And these are the children that are going to be the most significantly short. And they do have other stigmata that we can see both prenatally in the newborn period, including frontal bossing, communicating hydrocephalus, narrow foramen, and depressed nasal bridge. With the spine, we're going to have some narrowing of the interventricular distance, but they also have issues with their short pedicles and the lumbar lordosis of having some spinal stenosis. So here you can see some posterior scalloping and a little bit of anterior wedging, and look how short those pedicles are. And here again, you have a little more of like a rhizomelic shortening. The humeri and femurs should be longer than the forearm and tib fib. So here we have rhizomelic shortening, and then the trident hand. Chest, rib size can be a little hard. If it's subtle, I think at times we are not really very good at saying we think the ribs are short. You want to make sure, because a lot of the cartilage kind of courses anteriorly. You may get skeletal surveys with a very obvious small chest on your clinical exam, and we may not really necessarily mention what the ribs look like. The pelvis is very important in these cases. You can see kind of the narrow sacroiliac notch and kind of horizontal looking pelvis. And then again, the femurs are going to be short. You get a little bit of flaring of the metaphyses, and they can have kind of a long fibula. Now, when we move to the physis for the osteodystrophies, this is where your hunters and hurlers can fall in. They don't have as many changes to the epiphysis as the Morchios does, so they are not going to be as short, and they have more significant CNS effects. And for hypopid, you just kind of get delayed bone age. But here for the Mucopolysaccharidosis, you can just see how the kind of ground glass appearance of the metacarpals and this beaking at the base of the metacarpals is fairly classic for your Mucopolysaccharidosis or Dystocyasis multiplex. So if you kind of see that, you want to start thinking that it may be one of those patients. Again, they're going to have, unlike achondroplasia, they're going to have a normally wide interpendicular distance. They still may have some vertebral scalping. They still may have an inferior beak. So, big questions about was the patient normal in the newborn period, and is this something that has progressed? So here we have just examples of also spinal stenosis with hunters and hurlers. So you can have some similar abnormalities both with achondroplasia and the Mucopolysaccharidosis. Now with the hyperplasia, the metaphysis, you can get overgrowth. And then you can also have these strange ossifications. You get lead lines deposited in the metaphysis, but we can also have these strange things, something's called osteopoikilosis, where you have, they're really little dots in the metaphysis or lines, and that will be called osteopathia striata. I think they're clinically not that relevant, but they're very striking when you look at them on the X-ray. And then, so here's just some exostoses, both X-rays and sometimes 3Ds are helpful to help the orthopedic surgeons know what needs to be slimmed down. And I just like to throw this in because it's such a bizarre diagnosis, Malaria Stosis. I kind of put it in the spectrum of the osteoporosis and striata, but it'll kind of affect unusual sclerosis along one limb. This goes all the way along the foot. Now we can have hypoplasia, the metaphysis as well, so decreased primary spongiosa formation, so that could be your hypophosphatasia, and you can have decreased absorption, which will result in osteopetrosis. Now, for your metaphyseal dysplasias, there are a lot of subtypes, so you want to be looking at those metaphyses, looking for irregularity. These could be mimickers of, just a rickets, but they're going to be affecting the femoral heads. Looking at the wrists, looking at the knees are like the best bones to look for. And you're going to see kind of this flaring, irregularity. There could be some sclerosis, and you can end up having, abnormal physeal fusion. So here, this should catch your eye. So there's a little bit of irregularity to metaphysis, but what really should be catching your eye is all the metaphyses, all the bones are really, really dense. So in this case, this was an osteopetrosis. And you get these little weird bone within bone areas as well. So, so the configuration is actually pretty normal, but there is a mild irregularity to the metaphysis. But then you really want to look at the entire bone, and this did turn out to be an osteopetrosis. Now for dystrophies, rickets and lead poisoning can be big mimickers. And again, we'll have the cupping and fraying. They may have complete loss of the zone of superficial calcification, the rickets, but once they start getting treated, you may see it again. So the big difference here is with treatments, it's reversible. As we move down to the dysplasias of the diaphysis, you can have Osteogenesis imperfecta and the rare idiopathic juvenile osteoporosis. So, these are all the collagen abnormalities, and I'm not going to go into all the different subtypes. Radiographically, we kind of look at it. If they're lethal, we call it a type 2. If they're severe progressive but survive, call them a type 3. But you can see how getting all the skeletal survey is helpful. You can see here how thin the base of the skull is. You can get wormy bones. They may deliver and have some fractures, or they'll have already some bowing from in utero fractures. In older cases, the wormy bones can kind of help make you consider osteogenesis imperfecta. They may be thin and gracile, but they're kind of will look a bit washed out. These are your more classic type 3s that Dr. Tosi takes care of a lot of these, and you can chime in. But we see them quite often when they'll come in with, they just feel a little crack, and we'll look for these subtle fractures, which we can miss because you can see how abnormal the bone already is. It's very thin, osteopenic, and those little stress fractures can be quite subtle, and all the bones look pretty abnormal. So if you have a patient that really has a lot of pain and we're saying, no fracture, we could definitely be wrong, and kind of help tell us where you really think you're worried about where the fractures might be. So I tried to go really quickly through the run through of the systematic approach of doing a skeletal survey. It really is important to get all of the views. You really need the skull. You don't really know which bones you don't need. So I think you're doing a disservice to the patient for just trying to do one hand, one leg, and maybe an AP spine. In the long run, they're going to end up needing to get repeat films. So we want to get a full skeletal survey when possible. But at times a firm diagnosis really cannot be made. When I work with my trainees, I always push to say, what was the history? What do we know already about the patient? Work with the clinicians to figure out what the concerns are. We can at least give you all a little more of a tip of what to look for, can kind of help your workup be not as fast. And definitely consider follow-up exams or maybe doing some family surveys if other family members appear to be affected and yet they don't have a good diagnosis. And then lastly, just be aware if you get a clinician, a radiologist who gives it just one diagnosis. Because if they're right, they're worth their weight in gold, but if they're wrong, you really can have these patients walking around with the wrong diagnosis for years. So I really do prefer in my impressions, I always kind of reiterate the unusual findings and list them all, and then I'll try to come up with a differential. And even if it is like an amp mini, I'll try to come up with a couple of other potential diagnoses because it may be a dystrophy versus a dysostosis. So that's the presentation.
Dorothy, that was wonderful. Thank you. It's why we're all intimidated. There's so much to it, even for those of us who care for these kids on a daily basis. I can't thank you enough. So